Good morning, everyone. Welcome to the Orlando Journal Club for November. This is November 4th, 7 a.m. Eastern Standard Time. Let's get started. Our first randomized trial was published in Gastro this month. It's by Old et al. And it's a randomized trial looking at Barrett's esophagus surveillance versus endoscopy at need. Barrett's esophagus is a precursor for esophageal cancer, and current guidelines recommend surveillance every 3 to 5 years to detect dysplasia and early cancer. And surveillance endoscopy aims to detect early malignant progression. Large population-based studies have reported the annual risk of developing esophageal cancer in patients with Barrett's anywhere from 0.12 to 0.22%. And so, although widely practiced, surveillance for Barrett's esophagus has not previously been tested in a randomized trial. So these authors from the United Kingdom wanted to compare a 2-yearly endoscopy surveillance with no scheduled endoscopy, so as needed endoscopy in patients with Barrett's esophagus. This was a superiority randomized trial conducted in 109 centers across the United Kingdom. The investigators randomized patients with Barrett's esophagus in a 1-to-1 ratio to either a 2-yearly surveillance EGD or at-need endoscopy for patients who developed symptoms. And the minimum follow-up was 10 years, and the median follow-up period in the study was 12.8 years. The primary outcome was to compare the overall survival in the intention to treat population. This is the consort flow diagram for the randomized trial. After assessing for eligibility, the investigators randomized 3,453 patients, 1,733 to 2-yearly surveillance program, and 1,719 patients to at-need endoscopy. When comparing the baseline characteristics of the two groups, 2-yearly surveillance and endoscopy at need group, the mean age at entry into the study was 63 years for both groups. There were more male than female patients, 71 versus 29%. The length of Barrett segment overall was 2 to 3 centimeters in 41%, and greater than 3 to 8 centimeters in 46%. Time from Barrett's diagnosis to trial entry was mean of 46 months. The majority of patients were using PPI at the time of study initiation or study enrollment, with 94% being on PPIs. Low-grade dysplasia was present in 1% of study cohort, 35 patients. Patients who were newly diagnosed, so less than 4 months prior to study enrollment, was in 22% of patients. So the overall survival, there was no difference in overall survival between endoscopy at need and 2-yearly surveillance groups. There were 333 deaths in the surveillance arm and 356 deaths in the at-need arm. This resulted in an adjusted hazard ratio of 0.95 with a 95% confidence interval of 0.82 to 1.10. And on log-rank test, this resulted in a p-value of 0.520. When looking at the diagnosis, time to diagnosis of esophageal cancer, there were 40 patients with diagnosis of esophageal cancer during the study period in the surveillance group, and 31 patients in at-need endoscopy group. The adjusted hazard ratio for diagnosis of esophageal cancer was 1.32, with 95% confidence interval of 0.82 to 2.11. And on log rank test, this resulted in a p-value of 0.210. For cancer-specific survival, there was also no significant difference between the two groups, with adjusted hazard ratios of 1.01, with a 95% confidence interval of 0.77 to 1.33. Again, on log rank test, the p-value was 0.761. The limitation of this study is that there was no masking for participants and clinicians. And for the purpose of this study, endoscopy was offered every 2 years compared to current guideline of EGD every 3 to 5 years. The investigators state that the reason for this was because the study period was so long that there were changes in the guideline for EGD surveillance recommendations for Barrett's esophagus over this during this time period. The take-home point from this study is that surveillance did not improve overall survival or cancer-free survival in Barrett's esophagus. Next is a study in gut by Shin et al. This is use of a hemostatic powder for prevention of rebleeding in patients with non-variceal upper GI bleeding. This was a randomized trial from South Korea. Non-variceal upper GI bleeding remains a major cause of morbidity and mortality, and rebleeding rates following endoscopic treatment can reach up to 25% within 72 hours in patients with high-risk lesions. Next powder is a novel mucoadhesive powder that forms a strong gel barrier on contact with moisture, providing both mechanical hemostasis and mucosal protection. And delivery system uses low-pressure room air. The aim of this study was to evaluate the efficacy of the hemostatic powder, Next powder, in reducing rebleeding rates after conventional endoscopic treatment in patients with non-variceal upper GI bleeding. This was a randomized trial in South Korea. Patients with acute non-variceal upper GI bleeding from high-risk lesions who achieved initial endoscopic hemostasis were randomized in a 1-to-1 ratio to hemostatic powder or no further therapy. The primary outcome was rebleeding rate within 72 hours post-treatment. This is the consult flow diagram for the randomized trial. 348 patients were randomized to either the control group. This is just endoscopic therapy without powder, or to Next powder after hemostatic endoscopic therapy for hemostasis. And these were the baseline characteristics. 150 patients were finally included in the analysis of for the control group, 167 patients in the Next powder group. And as you would expect from randomized trial, there is no significant difference in baseline characteristics, including gender distribution, mean age of 64.7 years in both patients. Use of aspirin was in 17% of control group, 15.6% in the Next powder group. Clopidogrel use was in 12% of control group and 14.4% in the Next powder group. The comorbidities in the enrolled patients were stroke in 11.3% and 7.2% respectively. Underlying cancer, 5.3%, 6.6%, cardiovascular disease in 8% and 9.6% respectively. When looking at the bleeding characteristics in the ulcer subgroup of these patients, the majority of patients had Forest 1B or Forest 2A characteristics in ulcers. Initial bleeding cause was gastric ulcer in around 72% of the cohort, duodenal ulcer in the remaining. The hemostatic methods used were coagulation forceps in 46.7% control groups, 49% in the Next powder group. clip the use was 16% in control group, 13.2% in the next powder group. And thermal therapy was used, as you can see, in the majority of patients, and 96% of control group, 92.2% in the next powder group. When looking at the rebleeding rate at 72 hours and 30 days, you can see that there is a significant difference. If you look at this portion of the bar graph here, this is looking at the overall rebleeding rate at 72 hours. And as you can see, it was 11.3% in the control group, 2.9% in the next powder group with p-value of 0.005. This is the rebleeding rate in the ulcer subgroup. And again, a significant difference was noticed with bleeding rate of 12.0% in the control group versus 3% in the next powder group. For looking at rebleeding rate at 30 days, again, there was a significant difference between the two groups. Rebleeding rate was 18.8% in the control group, 7% in the next powder group with a p-value of 0.002. For the ulcer subgroup, the rebleeding rate at 30 days was 19.3% in the control group versus 7.2% in the next powder group with p-value of 0.004. In the ulcer group, the adverse events encountered were minimal: perforation of 0.7% in control group, anemia in the 0.7% in the control group. No adverse events were observed in the ulcer subgroup and the next powder group. The limitation of this study is that the observed rebleeding rates were lower than expected at 3% and 12%. And the number of rebleeding events was small, which then resulted in low fragility index. This means that if they had a few events, this would have shifted the results from statistically significant to non-significant. So, for example, if they had a few more rebleeds in the next powder group, it would have made the difference. It would have made the difference between the two groups not statistically significant. So this is something to bear in mind when looking at this study. Also, this study is based in Asia, where the high prevalence of H. pylori may have influenced the 30-day rebleeding rates. So the take-home point from this study is that the application of Next powder following endoscopic hemostasis significantly reduced both early and late rebleeding rates in patients with non-variceal upper GI bleeding. Okay, so for the journal recap, GI journal recap, journal club recap this morning, surveillance did not improve overall survival or cancer-free survival in Barrett's esophagus. And the application of Next powder following endoscopic hemostasis significantly reduced both early and late rebleeding rates in patients with non-variceal upper GI bleeding. Thank you so much for joining us this morning. Our next GI Journal Club is on December 3rd, 2025. Please have a wonderful day, week, and month, and we will see you in December.